Tissue damage and injuries. This content corresponds with Chapter 6 in the Foundations of Athletic Training, Prevention, Assessment, and Management text by Marcia K. Anderson and Gail P. Parr. Injuries can occur from different events, either large or small. Acute injuries occur from rapid onset, resulting from macrotraumatic events such as the picture on the left of the University of Tennessee football player. This football athlete, the one in the orange jersey, has had a very large macrotraumatic event injuring his knee. His entire lower leg is bent the wrong way, which resulted in fractures and dislocations of the knee. This type of injury frequently happens from one incident, and the patient can usually tell you exactly what happened, when it happened, and how. We also have injuries which occur over much longer periods of time. These are typically referred to as chronic or overuse injuries. Chronic or overuse injuries develop over a period of time from a series of microtraumatic events. Many of us have experienced low back pain, such as the pain exhibited in the picture at the right. Many times you can't distinguish exactly when it started hurting or what brought on the pain, but you just know it hurts. Approximately 80% of people will have experienced low back pain in our lifetime, and for the majority of us, eventually over time it resolves itself. However, that can't be said of all chronic injuries. Time does not necessarily heal all of them. So which one's worse? The simple answer is, if you're the one that's in pain, they can both be terrible. Acute injuries hurt immediately because of the large force or traumatic event, but we know exactly what happened, how it happened, and why it happened. Chronic injuries are typically a little less painful, but the pain tends to last for a much longer period of time. They can be very difficult to treat, as it's hard to determine how it happened or why. The way we treat these two types of injuries varies greatly, but is something we will continue to discuss and explore during this course. How do injuries happen? We start with tissues. This could be a muscle, a tendon, a ligament, a bone, a joint capsule, or other types of tissue. When forces are applied to tissue, the tissue has one of two responses. It can either adapt to the forces that are being applied to it, or it can fail. This is known as Wolff's Law. If the tissue fails from the force that is being applied, we have a disruption of the tissue, which is how injuries occur. So every time a football player gets hit during a game, why doesn't he get injured? He has muscles, bones, tendons, ligaments, and other tissue, and all of those tissues are being subjected to forces. So why aren't they injured more often? Well, there are several factors that can contribute to the risk of a force resulting in an injury. First, the magnitude of the force. The magnitude of the force has to do with how large the force is that you are being struck with. For example, you might survive being run over by a bicycle a little bit better than being run over by an automobile. The car has much more force potential and therefore could have a greater magnitude of force. In addition, the car also can travel at greater rates of speed and is also much heavier, which allows it to create a greater magnitude of force than does the bicycle. Second is the moment arm of the force. The further away from the axis point in the human body, this is typically the core, the less force is needed to injure structures. Third, the direction in which the force is applied. Typically, a perpendicular force, or a force that is at a right angle from impact, has the greatest amount of force. If a ball is thrown at you and hits you directly from a 90-degree angle, it hurts a lot more than if it glances off of you from a much shallower or much deeper angle. Next is the magnitude of the stress produced. The stress produced by the force depends on the surface area over which the force is spread. For example, a football athlete wearing shoulder pads, when he's hit, the force is distributed over the surface area of the pads. If the athlete wasn't wearing those pads, the force would be directed over very small areas and could increase the chance of injury. Last, the property of the tissue. Muscle, ligament, tendon, and bone all react differently to forces and stress. Muscle is a lot more elastic than bone, and thus can deform and retain its original shape. Bone can withstand large amounts of force, but does not have a lot of elasticity, which is great for holding us up, but really bad when the force exceeds the bone's capacity to withstand it. The mechanism of injury, or MOI, is a common abbreviation you will see within the notes. To understand the mechanism of injury, we need to define different types of forces. First, compression forces are axial loading that produces a squeezing or crushing effect. The weight of the human body constantly produces compression on the bones that support it. If you think of your spine, the discs are compressed between the vertebrae every time you take a step or move. Tension is axial loading in the direction opposite of that of compression. Tension is a pulling force that tends to stretch the object to which it is applied. This may feel good to start. Pulling on tissues is a common practice of massage and physical therapy. However, too much tension will disrupt the tissue and can actually result in tissue separation. Tension used to be a form of torture. It was called placing people on the rack. They would place tension on the arms and legs until the joints actually separated and the soft tissue did too. Eventually, the person was literally pulled apart. Shearing forces act parallel or tangent to the plane passing through an object. When a person stops quickly and the muscles of the quadriceps and hamstrings are not strong enough or do not activate quick enough, there's enough force for the anterior cruciate ligament, or ACL, to actually be sheared off of the femur by the tibia. This is referred to as a non-contact ACL injury. So if you've ever been watching a sporting event and you see somebody, it looks like they're running all by themselves, all of a sudden they fall to the ground and clutch their knee, there's a good bet that this injury has occurred. Bending are forces that cause one side of an object to come together. Every time you bend over to put your shoes on in the morning, you are creating a bending force in the spine. Now, the spine is okay with this bending force, but what would happen if this occurred to the long bone in your arm? The forearm wouldn't like it and would either have to adapt or fracture. Tension forces rotate in opposite directions from each other. The body does not respond well to torsion forces. When teaching individuals how to lift properly, the technique is always to lift with the legs, keep the object as close to the body as possible, and move the entire body as a unit. Do not twist. Twisting results in these torsion-type forces, and it doesn't take very much torsion, especially in the spine, to injure body tissues. Combinational or combined forces are any combination of the aforementioned forces. This could be a torsion with a compression, or a shear with a torsion, or any other combination. Combinational forces typically result in very complicated injuries. Our muscles are like a rubber band. We see in the picture a rubber band being stretched between a thumb and the first finger. Our muscles act in much the same fashion as this rubber band. We can stretch our muscles within a certain limit and they will retain their shape, just like this rubber band. But what would happen if we extend our fingers just enough with this rubber band? Eventually, it's going to break. Our muscles have the same type of property. When this load exceeds what's called the yield point or the elastic limit, our muscles can no longer keep their elastic shape. Eventually, the muscle tissue will fail and becomes what is called plastic, which means it no longer retains its elastic type property. Joints can be classified in different ways, but are describing similar things. Structural classifications of joints focuses on the material binding the joints together. Functionally, joints are classified by how much movement is allowed by the joint. Essentially, the classifications are describing different features at the same joint type. A fibrous joint is the same as a SYNARTHRODIAL joint, a cartilaginous joint is the same as an EPIPHYSEAL joint, and a SYNOVIAL joint is the same as a DIARTHRODIal joint. This table might be helpful as a visual representation for the different classifications of joints. Functionally, joints are classified by how much movement is allowed by the joint, and structural classifications of the joint focuses on the material binding the joints together. For example, a synarthrosis joint has no movement. Some structural categories of joint examples are sutures, which occur in the bones of the skull. When we are babies, the sutures are not closed, thus allowing the baby to pass through the birth canal. As we age, these sutures close to provide protection for our brain. Glomphus joints bind the teeth to the maxilla and mandible. Synchronosis joints are rigid cartilaginous bridges between two articulating bones, like the cartilaginous connection between the ribs and the sternum. Synostosis are typically rigid, immovable joints created when two bones fuse and the boundary between the two bones fuse, such as the junction between the manubrium and the sternum. Ampiarthrosis joints have little movement. Some structural categories or joint examples are the syndesmosis, which is where a band or ligament connects bone, such as the articulation between the tibia and the fibula, or the ulna and the radius. Symphysis joints occur where the bones are separated by a wedge or pad of fibrous cartilage. The pubic symphysis between the two pubic bones is an example of this type of joint. Lastly, diarthrosis joints have free movement. An example of structural category or joint examples are synovial joints. These are the types of joints most people think of when they are asked to think of joints, as they're typically located at the ends of long bones, such as those in the upper and lower limbs. Here are some pictures of fibrous or synarthroidal joints. Again, they're held together by fibrous tissue, they're immovable, and some examples might be either the sutures or the teeth. Cartilaginous or ampiarthroidal joints are united by hyaline cartilage or fibrocartilage. They're slightly movable, and here are some examples. Synarthroidal or diarthroidal joints. They're most commonly seen in the joints of the limbs. They're freely movable. The next slide has some pictures as examples of synarthroidal or diarthroidal joints. In this picture, we have at the top left a hinge joint. We have one concave and one convex surface. It allows for the motion of flexion extension. This is a picture of an elbow joint. At the top right, we have a pivot joint. This is a rounded end that is rotating within a sleeve-like bone. This is a picture of the atlantoaxial joint. The middle left is a picture of a saddle joint. This is a biaxial joint that is saddle-shaped. This is a picture of the carpometacarpal joint of the thumb. The middle right is a condyloidal joint. It has a concave and a convex surface that move reciprocally. The picture is of a metacarpal phalangeal joint of the finger. At the bottom left, we have a ball and socket joint. This is a spherical head and a cup-like socket. This is a picture of the hip joint. At the bottom right, we have a plane joint or a condyloidal joint. This is two flat surfaces that glide upon each other. This is a picture of the acromioclavicular joint in the shoulder. Synarthroidal or diarthroidal joints have 5 key features. Number 1, they have articular cartilage. 2, they have synovial cavity. Number 3, they have an articular capsule. Number 4, there is synovial fluid. And number 5, there is reinforcing ligaments. All synovial or diarthroidal joints share these 5 key features. Some may also have articular discs or labrums inside the joint. Our next section of the lecture is the classification of injuries. We will go through each of these in a little bit more detail, including soft tissue injuries, which include skin injuries and musculotendinous injuries, joint injuries, bone injuries, and nerve injuries. The integumentary system comprises the skin, hair, nails, and glands of the skin and is the largest organ of the body. It provides protection and sensation. It regulates fluid balance and temperature and provides vitamin D and the immune system components. The skin is composed of 3 regions. The outer layer is known as the epidermis. The epidermis has multiple layers containing pigmented melanin, hair, nails, sebaceous glands, and sweat glands. The outer surface is made up of dead epithelial cells, which is replaced every 3 to 4 weeks by new cells that are pushed up from the dermis. The dermis is the middle layer and is the largest portion of the skin. It provides both strength and structure for the skin. The dermis contains blood vessels, nerve endings, hair follicles, sebaceous glands, and sweat glands. The bottom layer is the subcutaneous tissue, which is largely comprised of adipose tissue, which provides cushioning between skin layers, muscle, and bone, and also helps to regulate body temperature. When examining skin wounds, the acronym APAIL is sometimes helpful to determine which type of skin wound has happened. Abrasions are skin scrapes that are due to a shearing force. A puncture occurs when a sharp cylindrical object penetrates the skin. An avulsion is a severe laceration and complete separation of the skin. An incision is a clean cut, and a laceration is an irregular tear. Blisters are also types of skin injuries. This occurs when different layers of the skin are exposed to friction. Typically fluid or sometimes blood accumulates between the layers of the tissue. A skin bruise is exactly what it sounds like. It's a hematoma that occurs underneath the skin's layer. Most of us have had one of these types of injuries at some point in our lives. Musculotendinous injuries. These include muscle cramps and spasms, muscle contusions, strains, tendinopathies or tendinitis, tendinosis, or tenosynovitis, and heterotopic ossification, also known as ectopic calcification and formerly known as myositis ossificans. Muscle cramps and muscle spasms. Muscle cramps are painful muscle contractions that are due to electrolyte imbalance and muscle fatigue. They may be a result of dehydration, improper nutrition, or possibly improper warm-up. There has been some debate recently regarding pickle juice and mustard to treat muscle cramps. There is a lot of evidence from athletes who claim that these are the miracle cure. However, science has not quite caught up yet. There is a little science that suggests that the vinegar within the pickle juice and the mustard may help prevent muscle cramps. Currently, pickle juice is being marketed in the same way as Gatorade as an electrolyte imbalance solution to help with sports injuries. Muscle spasms are painful contractions that are caused by a reflex action. When a muscle is exposed to pain, a strain, or an unexpected force, it spasms as a protection mechanism. With this muscle spasm, it tends to cause more pain, which causes more muscle spasm, creating what's called the pain spasm cycle. Musculotendinous injuries. These include muscle contusions. These are bruises that occur underneath the skin. The mechanism of injury is an acute or direct blow. Usually this is a compressive force. Ecchymosis or bruising is often present and can be very painful, especially to the touch. It forms a hematoma underneath the skin. It's very common to affect large muscle groups, like in the pictures. Upper right, we have a picture of the biceps, which has a hematoma, and the lower right, which is the quadriceps with a hematoma. We can tell that the lower right picture is a little bit older bruise by the coloring. When bruises first occur, they're usually a reddish or purple color. As they start healing, they turn kind of a green or yellow color. Muscle strains. These are stretching or tears of the muscle or tendon. It's easy to remember strains because they occur at the tendon. Both the strain and the tendon have a T in them. These occur most commonly at the musculotendon junction or within the muscle belly. Grade 1 occurs when the stretching of the muscle fiber or micro tears occur. Grade 2 is a partial tear, and grade 3 is a complete rupture. Within the grading scale for the muscle strain, we can also see associated losses of function, weakness, and pain. With a grade 1 muscle or tendon strain, we can see that most patients are going to experience pain. However, weakness and loss of function does not typically occur. With a grade 2, we have pain and weakness, and a grade 3, the patient is going to complain of pain, weakness, and a loss of function. Tendinopathies are any tendon pathology. The mechanism of injury is insidious and is typically overuse. There are 3 types of tendinopathies. Tendinitis is inflammation of the tendon. Tendinosis is degeneration of the tendon itself, most likely to happen as partial or full thickness ruptures of the tendon. Tenosynovitis is an inflammation of the synovial sheath surrounding the tendon. An example is de Quervain syndrome. If you grasp your thumb inside your fist and you ulnarly deviate, you may experience some pain on the radial portion of your wrist. If you do, this potentially could be the start of tenosynovitis. It's very common in the hands and feet. Heterotopic ossifications, also known as ectopic calcifications. They were previously known by myositis ossificans. These are formations of a bone within a muscle belly's fascia or within the muscle itself. The mechanism of injury is insidious after an initial trauma and could be from repetitive hits. These are very common in soccer players and in football players. We can see the X-ray in the upper left. There is a picture of a calcium deposit within the gastrocnemius muscle or the calf muscle right behind the knee. We also have in the bottom picture an X-ray of a myositis ossificans at the distal calf within the Achilles tendon. These are both pictures of soccer players who were unfortunately kicked repeatedly in the back of the calf where there isn't any protection from a shin guard. We see this commonly in the quadriceps and the forearm of football players as well. Joint injuries include sprains, dislocations and subluxations, osteoarthritis, and bursitis. A sprain is a stretch or a tear of a ligament and/or the joint capsule. The mechanism of injury is the joint is forced beyond its normal anatomical limit. The grading for sprains is very similar to that of strains. The difference between a sprain and a strain is the type of tissue that's involved. Sprains involve ligaments, strains involve muscles and/or tendons. A grade 1 sprain includes stretching or micro tears of the ligament or capsule. Grade 2 is a partial tear, and grade 3 is a complete rupture. Dislocations and subluxations. Dislocations are complete separations of the two adjacent joint structures. The mechanism of injury is typically acute and occurs from passive stretching of the joint beyond its physiological capacity of the capsule and the ligament. In first-time dislocations, it should be treated as a possible fracture and should never be reduced, unless it's being done in an emergency department. As an athletic trainer, we never reduce these first-time dislocations. Now, if somebody has dislocated multiple times, there is a good chance that an athletic trainer can be trained how to reduce a dislocation. One of the most commonly dislocated joints is the shoulder. This happens really commonly in sports when the arm is flexed to 90 degrees and externally rotated. The arm gets pulled backwards, and eventually the shoulder actually dislocates anteriorly. A subluxation is a partial separation or a joint that dislocates and spontaneously reduces itself. The mechanism of injury is acute or chronic. Overloading of the joint in a position of little static or dynamic stability. Your patient is going to complain that their joint feels unstable. Osteoarthritis is a chronic degeneration and softening of the articular surfaces. The mechanism of injury is insidious and chronic or could be related to previous trauma. For example, people who have torn their ACL tears, about 85 to 90% of them will develop osteoarthritis at some point in their life. Many times this osteoarthritis becomes bad enough that they actually end up having to have a joint replacement. This most often affects the weight-bearing joints such as the knee. It's very common also in the wrist and the ankle. A bursitis is an inflammation of the bursa. The bursa is a fluid-filled sac, and it reduces friction between the tendon, muscle, and ligament, and also helps facilitate smooth motion. The mechanism of injury for bursitis can either be acute from a direct blow or insidious as an overuse injury. Here are some pictures of chronic versus acute bursitis. The picture on the left are 4 of the most common bursa located within the knee. We have the suprapatellar bursa, prepatellar bursa, infrapatellar bursa, and the pes anserinus. When people spend long periods of time on their knees, such as tiling a floor or maybe even mopping a floor, they can develop prepatellar bursitis. It is the most common out of the 4. Prepatellar bursitis is also known as housemaid's knee. Most people are unaware that they even have bursa until they become inflamed. We can see in the upper right-hand picture an example of Achilles tendon bursitis. The left foot is extremely swollen. In the bottom right-hand picture, we have a bursitis of the elbow. It almost looks in this picture as if there is a structure within the elbow itself. That is the swollen bursa. Again, we would never see this until that bursa becomes inflamed. An inflammation to the superficial bursa can be very dramatic. For bone injuries, we have bone bruises and fractures. Fractures are disruptions of the continuity of the bone. There are different types, open versus closed. There are many different types of fractures, but the most common are simple fractures and compound fractures. Simple fractures are also called closed fractures. These are where there is no open wound on the skin. The bone has not pierced it. Simple fractures include a green stick fracture, which is where the bone is bent and has not completely fractured. These are very common in young children where the bones are not fully solid. The bone splinters instead of fully fracturing. A transverse fracture is when the bone breaks across at a right angle. An avulsion fracture is when there is a separation of a small fragment of the bone near the attachment at the ligament or tendon. Oblique fractures are when the fracture is at an angle and the bone stays at an alignment. Oblique displaced fractures occur when the fracture is at an angle but the bones do not stay at an alignment. A comminuted fracture where the bone is fragmented into multiple pieces. Segmental fractures are when the fracture occurs in two parts of the same bone. A spiral fracture is when the bone fracture occurs at a torquing or twisting motion. This type of fracture is common during activities where one extremity is planted. Compound fractures, also called open fractures. This is when the bone breaks through the surface of the skin, but does not necessarily mean that it will stay there. Some compound fractures may move back into the wound so that it is no longer visible. There may be graphic content in the pictures for the rest of the slides and for the rest of the class. These pictures are not meant to gross anybody out, rather they are meant to illustrate the importance of these different types of injuries and the treatment that you could provide. For bone injuries, please know the different types. They are listed in figure 6.13 on page 151 in your text. There is a good possibility that test questions in the future may come from this table. Epiphyseal injuries or Salter-Harris fractures. Salter-Harris classified these different types of physeal fractures. An epiphyseal injury occurs at the growth plate. This is typically seen in young athletes. Type 1 is straight across. 5% of fractures are type 1 fractures. Type 2 is above the epiphyseal plate. This means above the growth plate. Approximately 75% of fractures are type 2. Lower or below is type 3. 10% of fractures are type 3 fractures. To or through or transverse is a type 4. 10% of fractures are type 4. Erasure of the growth plate or crush injuries are type 5. They're very uncommon and less than 5% of all injuries occur as type 5. The higher the classification, the greater the risk of complications and the worsening of the prognosis. Type 2 is the most common. Approximately 75% of Salter-Harris fractures are type 2. Salter-Harris injuries are very important to growing athletes. If that growth plate fuses prematurely, one bone could end up a lot shorter than another. This may not be quite as big of a deal in an upper extremity, but could be very significant for the lower extremity bones. Stress reaction and stress fracture. A stress reaction is an irregular surface to the bone due to altered bone metabolism. If you take your fingers right now and run them down the shaft of your ulna or along the shaft of your tibia, you may notice that there are little indentations and divots within the bone. At some point during your life, you've probably bumped into things, and there is a stress reaction that occurs to the bone. A stress fracture is a type of incomplete fracture that is due to repetitive stress. This is common in the lower extremities, and it's hard to diagnose. Most of the time, patients are complaining of night pain. Stress fractures, these are some pictures for examples of stress fracture. X-ray is not very reliable. Unfortunately, stress fractures only show up on X-ray when they're starting to heal. We can see the picture of the foot. This is an X-ray of a stress fracture of the second ray. Unfortunately, this only showed up approximately 10 weeks after the fracture. We can also see a picture in the left hand area of a stress fracture to the neck of the femur. This too only showed up approximately 8 weeks after the fracture. We can see better pictures of stress fractures through MRIs or bone scans. Peripheral nerve injuries can have different mechanisms of injury. These can either be acute or overuse. Compression injuries occur, such as the tarsal tunnel syndrome. Stretching, traction, or contusion can happen. Examples are stingers or burners, which are brachial plexus traction or compression injuries. A transection is a laceration of the nerve. To understand nerve injuries, we need to define different types of sensations. Hypoesthesia is a reduction in sensation. Hyperesthesia is a heightened sensation. Paresthesia is a sense of numbness, prickling, or tingling. Neuralgia is chronic pain along a nerve's course. This could be due to irritation or damage of the nerve. A neuroma is a mass formed around the nerve. We can see in the picture, number 1, labeled in the picture, is a swollen digital nerve. Number 2 is the Morton's neuroma. This is a growth or benign tumor of nerve tissue. Number 3 are branches of the digital nerve. So what are the clinical features of a neuroma? Normally there are no outward signs, such as a lump. Nerve pain includes burning pain sometimes in the ball of the foot and can radiate into the toes. The pain generally intensifies with activity or wearing shoes, but night pain is rare. There is also numbness sometimes in the toes or unpleasant feeling. Runners may feel pain as they push off from a starting block. Also, those who wear high-heeled shoes, it puts the foot in a similar position to the push-off and can aggravate the condition. Tight, narrow shoes can also aggravate this condition by compressing the toe bones and pinching the nerve. Unfortunately, to deal with this type of neuroma, most of the time surgical intervention is the correct option.